It was on the 13th day of January 1889 that the first death of a footballer in action was recorded. 26-year-old William Cooper of Star Valley Football Club died of a ruptured bowel in a match against Grimsby Town. He died a day after the incident in England. In Africa, the list is long, but we may be quick to remember the 2003 death of Mark Vivian Foe while playing in the FIFA Confederations Cup semi-final for Cameroon against Colombia. He died shortly afterwards in hospital with the revelation that hypertrophic cardiomyopathy is the cause of death of Mark Vivian Foe. Over 111 footballers have died in action or shortly afterwards since the year 1889 all over the world. Nigerian players are among the 111 and still counting. On the 12th day of August 1989, Samuel Okwaraji died aged 24 while playing for Nigeria against Angola in an Italia 19 World Cup qualifier at the National Stadium in Lagos. Amir Angwe of Julius Berger followed in 1995, and heart attack is recorded as the cause of death of Amir Angwe. Johnny Koroma and Wilson Mene equally died in the field of play, while Orobosan Adun, goalkeeper of Wari Wolves, died due possibly to the consequences of beatings he received from fans of Enugu Rangers 3 days earlier. Endurance Idaho of Al-Merrek Football Club of Sudan died of heart attack in the year 2010, and Victor Omogbehin also gone in the same year 2010. Well, the cause of death of Bobsam Elejiko remains unclear. What is clear is that Chinonso Henry died of heart failure in the year 2012. Joining me in this week's edition of the program Sports Chat to discuss sudden death in sports, and with particular reference to football, is the head of Department Sports Medicine of the National Sports Commission, Dr. Abdulkadir Muazu. My name is Amanzi Marcus. Yeah, welcome to the program.
Thank you very much, Marcus.
Yeah, you have heard me giving a list, a rundown of some of the Nigerian footballers that have died in the field of play. Before we really go into the issue of this sudden death among footballers, I want you to reflect back to the history of this problem.
Well, I thank you very much, Marcus. You have vividly illustrated the history of this problem. The first death probably wasn't a sudden death. As you said, it was due to a ruptured viscous. But most of the deaths you have enumerated in your introductory report were sudden. Sudden means a player collapses without contact on the field of play, and within minutes he is pronounced death. So it's called sudden cardiac death. Cardiac means heart. So a lot of these deaths were attributed to heart attack. The heart, as you may recall or you may know, is like a pump, and is pumping in a very rhythmic and regular manner. So occasionally something happens, and there are many causes of that. And then the heart will begin to fibrillate. Okay, sir. So before you go into the details of explanations of cardiac arrest, I want you to reflect back, let's say in the Olympics, in those years that the Olympics started, yes, were there cases of sudden death among athletes? There had always been cases of sudden death among athletes. But the question would be, when was the first one recorded? And I'm honestly I'm not a good historian. I can't recall that. But we have always known that there are people who have some problem with their heart, and if they exercise, the heart may stop and they may drop and die. We can go into history. During the Olympics, or even before, or even when people were hunting, pursuing prey, some people just collapse and die. And we are aware of many stories of our own people in all societies and communities where people sometimes just slump and they die. Many of these causes of death is due to the fact that the heart stops. Of course, there are other causes, but the predominant causes of sudden death among people who are exercising is due to heart attack. We're all taught in secondary school in biology that the heart is a pump, okay? And it pumps blood to the body. And we know blood carries what we require to live. Blood carries oxygen, and blood carries other nutrients to our organs, to the heart itself, to the brain, to the muscles. Now in sports, as you know, when you begin to get more physically active, even if it's just walking, as you walk faster, you find that your heart beats faster, which means that there is increasing demand for more blood to meet with the demands of the muscles that are exercising. So in exercise, that pump is required to work more. So there are people who, and for that to work more, the pump must be efficient. It must be able to function normally. And it's a very definite rhythmic pumping mechanism, where the heart pumps very rhythmic. At rest, maybe 70 times. But when you are exercising, this may be after 110. Now, if the heart is pumping like this...
110 in a minute? Or
yes, in a minute, yes. At rest, maybe 70. With athletes who are very fit, when they are resting, the heart, because the heart is very efficient, the pump is efficient, it pumps slower, maybe 60 per minute. But for me and you, maybe 70 to 75, or up to 80 is fine. But there are many conditions that will make the heart to stop pumping in a normal functional way. And it goes into fibrillations like this. When that happens, the pumping mechanism fails. So the heart is not able to effectively and efficiently pump blood and oxygen to the organs. And because the heart itself depends on blood supply to continue to pump, the heart stops. And of course, when it stops, the pumping stops, and then the brain doesn't have blood, and the patient collapses. And if you don't revive the heart within a reasonable time, typically 2 minutes, then the patient is likely to die.
So like these Nigerian players I have mentioned, among the 111 and still counting that have died all over the world, it was the same scenario that led to their death? I mean, Angwe, Okwaraji, and the others?
Yes, it was the same scenario. I wasn't on the field when Sam Okwaraji collapsed and died, but I was the venue medical officer at Onukan when Amir Ango collapsed and died. And I was the first person to be on him on that pitch. And I'm almost certain he died of heart attack. We didn't have much understanding of the mechanism then as we do now, or what to do immediately. So what we started to do, rather than pumping the heart, trying to stimulate it to pump more, we're trying to give him more oxygen. Unfortunately, we lost him. So it's the same scenario. The only question is what causes the heart to stop, and there are many of them. You have mentioned one, which is hypertrophic cardiomyopathy. In simple terms, the muscles of the heart get big, okay? They hypertrophy, and there are divisions in the heart. They also get big, so the pumping mechanism becomes compromised, and the heart can stop. And then even common cold that can cause somebody to have catarrh. The virus can affect the heart and cause inflammation of the muscles of the heart, and it affects the pumping mechanism, and the heart can stop. So most cases of sudden death, that's why it's called sudden cardiac death, is caused by problems with the heart.
Okay, in February and March of the year 2015, the League Management Company and the Nigeria Football Federation organized a medical course for team officials, medical team officials of the 20 Premier League clubs in Nigeria and from the national teams, the football teams.
Yes.
Of what relevance is that a workshop to the issue of sudden death among players?
Now, we realized many years ago that we have a huge challenge with sudden cardiac death in the country. In Africa, we have the highest incidence. There are many that have not been recorded, but from what you have said, we can recall up to 9 incidents in the last 15 years. That is very high. And there are many who have died that don't have access to media or to any reporting system, and we haven't heard about that. So every responsible country will have to try and do something about it. And it's in the news. If an athlete collapses and dies before cameras, the world knows. So we began to ask ourselves questions. What can we do either to prevent athletes collapsing and dying, or to be able to empower ourselves to respond appropriately and properly to save the life of an athlete who collapses with a heart attack? And we devised 2 strategies: prevention and intervention. So we started to initiate a very comprehensive pre-participation screening, heart screening for all those who are playing in the league. And we are following suit of what happens in FIFA. Before players go for a World Cup or even Cup tournament, they have to undergo screening. So we initiated that as a policy, guidelines to all clubs. It was abused initially, but we enhanced it. So every player now that goes to play in the league comes with a medical report that satisfies him fit. He has a comprehensive heart screening, so that we'll be able to detect abnormalities like hypertrophic cardiomyopathy. So if we pick, and we have picked some who have hypertrophic cardiomyopathy, and then we go on to do echocardiogram to ensure that yes, it is, and then we advise the player appropriately. That is trying to prevent. Intervention is to see what we can do for emergency response. That if somebody collapses, because players will collapse, we are able to respond. And the best way to respond today is to be able to effectively use CPR, which is cardiopulmonary respiration, resuscitation, and then use correctly an automated external defibrillator. So we are trying to do what is possible to save the player.
So this equipment that we saw during the training is meant to arrest a cardiac arrest?
Yes. If a player dies and you are able to respond within 20 to 30 seconds, and you are able to do correct external cardiac compression, which means trying to stimulate the heart to come back, and you are able to correctly use an automated external defibrillator, you have a very good chance that that player will survive.
So in essence, you are saying that if the AED machines that you now have, if they were available in 1995 when Amir Angwe died, he would not have died?
It will probably have saved him. I'm a Muslim, so we believe when the time comes you go, but we will probably have saved him, because I entered, the only thing I had was my hand and oxygen. And unfortunately, that didn't work. So we are relying more than on resuscitation itself. But now we realize that you have to do more of compression. We did compression, but we are doing compression at a ratio with resuscitation that is not practicable now. So these machines are indispensable. That is why now, before any match starts that is organized by FIFA or CAF, they ensure that defibrillator is present by the sideline. And that is what we want the league to also do, because we are not only striving to save our national players, we should also strive to save every player who plays football in Nigeria. So our department, the NFF and the league management company work in collaboration to get these AADs for all clubs, and then to get them to come so that the medical staff are able to get comprehensive training.
And they were trained that day?
Yes, yes.
They received the training?
Yeah, they received the training over a course of 8 hours, theory and practical, actually demonstrating with the machines, including airway management. So we're very happy that we have been able to empower the medical staff of clubs to be able to save the life of their players if they correctly employ the machine as they were trained.
Okay, Dr. Abdul Kadir Muazu, Head of Department of the Sports Medicine, National Sports Commission. Can you say you have enough facilities in the sports medicine centers of the National Sports Commissions nationwide?
Nationwide, I cannot say enough. But I think we are very well equipped to handle emergency, especially in Abuja, Kaduna, Enugu, Ibadan, and Lagos. Thanks to our many efforts of the country to host FIFA tournaments. So we tried in the course of planning for medical care to leave legacies. And many of those legacies were very sophisticated emergency medical equipment. The challenge we do have is that the people who are supposed to use these equipment are not fully trained and competent to use them.
So when are you training them?
We are training them. Some of them we can train ourselves, and we do that at the National Sports Commission practically every year. From our budget, we organize comprehensive medical, we don't even call it football, it's sport emergency medicine training. Using stimulators, simulating incidences. And then we also have very advanced life support ambulances that we can convey a player to the hospital. But beyond that, as you know, sport medicine is not only treating emergencies. We want to treat injuries, we want to make sure athletes recover, we want to enhance their performance. It's not a medicine that only seeks to treat pain, no. It's a medicine that is committed to enhancing. Not only do we want them to remain healthy and fit, but we want to make sure that when they compete, they are able to compete to win. No Nigerian university as at now offers any form of postgraduate training in sport medicine. What we are trying to do, because we are a large country with a large population, is to see how we can stimulate some universities. The University of Port Harcourt is interested. They are trying to develop a program, and hopefully, if the faculty is right, they may begin to offer some courses in the near future. But to be realistic, we feel that it's better to enhance the capacity of those who are already here. Okay. And we do that not necessarily by insisting that we have to offer postgraduate training. We offer training so that everybody who is involved with athletes' health is able to provide some basic care to those athletes.
So the meaning is that you recruit within those who have graduated in general medicine?
Yes.
Okay.
Yes. So what we need in a realistic way is to get very good doctors who are competent to practice general medicine. And then we take them before we put them to teams and train them over a couple of weeks. We call it induction training, so that at least they are conversant with the basic issues of sport medicine. Injury treatment, injury rehabilitation, self-participation, and so on, all aspects of sport medicine.
How is sports medicine different from the normal one we know we go to hospitals if we are sick?
I tell you, sport medicine is a performance medicine. It has to do with all scientific and medical issues that have to do with sports and exercise. And it's a very young branch of medicine, but it's a huge area that touches on injury treatment, injury diagnosis, injury rehabilitation, recovery, sports nutrition, exercise physiology, sports psychology, biomechanics, and so on and so forth. So it's a wide area. That's why it's one of the most difficult postgraduate training to undergo, because you're not only training to be a surgeon or training to be a pediatrician. In sport medicine, there is surgery. In sport medicine, there is pediatric sport medicine. We have sport medicine related to women. So it's a very large area that touches all aspects of medicine that have to do with sport and exercise.
So can you say that in the areas we've enumerated, Bauchi, Kaduna, and Enugu and Lagos, you have the personnel?
We have the equipment, okay, and we have few personnel. Okay. You recall that those areas I mentioned actually had the benefit of hosting either the under 17 or under 20 World Cup, either 2009 or 1999. So we do have the equipment because that was what was prescribed by FIFA. But we also have staff who are trying to provide some care. We are not yet there, but I can't say we have enough.
Okay, Dr. Abdul Kadir Muazu, as the head of Department Sports Medicine of the National Sports Commission, you are also heading the Sports Committee of the Nigeria Football Federation.
Yes.
And that now brings me to the question of who qualifies to be in the medical team of the national teams.
Yes, it's just repeating. Any good doctor, because the ideal is that you should have somebody who has had a formal training in sport medicine. But if I tell you we are not more than 10 doctors, maybe we have 4 within the National Sports Commission that have actually undergone any postgraduate training in sport medicine, then it becomes obvious that we cannot have a postgraduate trained sport medicine doctor for every national team. Because in football alone, we have probably maybe 8 teams. So I can't have all my trained doctors to go to football when I have to take care of basketball, of wrestling, of weightlifting, and so on. So what we do is to identify doctors, and we have many colleagues who are good, and then put them through some training, like the one we held. Send them for some short courses organized by CAF and FIFA, so that they are able to stimulate, to acquire those basic skills and competence they require to provide effective care. But working with FIFA, I think from June this year, FIFA is introducing what they call Diploma in Sport Medicine. And it will be the minimum requirement for any doctor, officer, or therapist to be attached to national team. And the course will be offered online. So we are hoping to use this opportunity and that window to train everybody who wants to do. So we will call on all doctors who are interested, not only those who are working with the National Sports Commission. If you are interested to be involved with football, enroll and train yourself and get the FIFA diploma, and then you are welcome to be a national team doctor.
Well, we are gradually coming towards the end of the program. Dr. Abdul Kadir Muazu, HOD Sports Medicine Department of the National Sports Commission. What is your message to Nigerian athletes who some of them may be deceived into engaging themselves in drugs?
That cheating in life, not only in sports, does not pay. And that doping, that is using an enhancement substance, any substance to enhance performance, is dangerous to health, is anti-ethical to sports, because sports stands for everything that is positive. Fair play, being sincere, being good to your competitor, and not cheating. So my message to all athletes and coaches, because we have just come to discover that coaches are part of our problem of doping in this country, is that it doesn't pay. It doesn't pay because if you look at this young Amalaha, who came before the world and achieved an incredible feat at 16 years of age, winning a Commonwealth gold medal.
In weightlifting. In
weightlifting, only to be so thoroughly disgraced and humiliated just 48 hours after. You know that it doesn't pay to cheat. It doesn't pay for the athletes. It doesn't pay for those countries that represent the athletes. So I'm appealing to everybody who is involved in sports to try and understand what is doping. Why should athletes dope? And then educate the athletes and make sure that coaches are held responsible and liable for any athlete that is found to be doped under their care due to their carelessness.
So your message is that they should not involve themselves in any form of cheating? Any form of cheating.
The message we give athletes when they come to camp is that don't take anything at all without clearance from your doctor. Because there are many simple things that the athletes feel is safe, multivitamins or cold medicines, that are banned. So, and ignorance is never an excuse in doping.
Well, thank you very much, Dr. Abdul Kadir Muazu, Head of Department Sports Medicine of the National Sports Commission. You have spoken about sports medicine in Nigeria, and I'm sure that those who watch this program from the beginning will have learned one or two things. That is how we draw the curtain in this edition of the program Sports Charts. I am Amanzi Marcus. Thank you very much for being part of this edition of the program. Stay tuned as more interesting programs come your way from this channel.